We're starting a new team, all new. So it's really, really tricky to figure out where to start when you're doing just hourly teaching. So I'm gonna start out how to describe a CTG. That's just the basic principle of how we do things around here, because they are slightly different. And also a bit of guidance about how to prepare presentations for the future. Because that, again, is a very, very important thing. Our videos go online. There's a channel, there's a YouTube channel that we actually record all of this on, which means it's very, very important. Patient information, staff information, discussions have to be within a recordable, presentable video live kind of thing. Yeah, so that had to go through a lot of medical legal and risk assessed forms and requirements that we have to fulfill. Okay. So how do we assess CTGs? How do we assess fetal monitoring? Remember that fetal monitoring is only part of the entire clinical picture. We don't assess fetal heart rate traces, we assess the fetus. That is our concentration. We're trying to make sure that baby and mom are both well. Does that make sense? Yeah, so it's only part of a big, big picture. Our CTG assessment starts before we ever enter the room. It starts at the handover area. That's when we're figuring out, okay, why am I seeing this lady? Why am I going to see her? Why is she on the label board to start with? Okay, that's the entire concept of it's only part of the big clinical assessment. Okay, how old is this baby? How far along gestational age? And any antenatal events that has happened leading up to this point. That is the handover board, no? So we talk about this is a primary gravida or whatever. This is the gestational age, and this is why she's here. Let's go through this as we're going through a patient. So our patient today is a primary gravida. She's 40 weeks and 2 days pregnant, and she's coming for induction of labor for abnormal uterine artery Dopplers at 20 weeks. Okay, from this information, I am trying to think, okay, why am I monitoring this baby? Why am I monitoring this baby? You guys sitting in front of me, so.
So if normal uterine artery Dopplers,
which means?
So it means that there's probably some kind of possible placental insufficiency.
Yes. So I need to make sure that this baby has enough reserves, or I know that it had normal growth scans, so it had enough to help it grow, but does this baby have enough reserves to take it through labor as well? Okay, so that's what I need to be looking for. Okay, and she was admitted for induction. She didn't actually get prostaglandins because she was found to be already 2 centimeters dilated. So all we did was transfer her to labor ward and we air-end her. Okay. This is the handover room. That's the handover that we got in the handover room. What do we do after that? So on a ward round, on a day, we've just had the handover in front of the board. What do we do after that?
Go to the room, see the woman, talk to the midwife before you go in.
Talk to the midwife before you go in. So you knock on the door, she brings the notes out, we have a look through the notes. The idea is to look at her previous assessments for ourselves. We need to figure out what this baby's monitoring has been, what its norms are, and we set up the norms. So this is what it was in the past. Now, the CTGs are presented so that they're anonymized to, there's no patient information, there's no signatures, so there's no staff information. You can see there's no date either. Okay, so there's no way of actually knowing where this CTG comes from, even which hospital. Nothing that can identify neither the hospital, nor the staff, nor the patient. Okay, and we look at the previous traces. What if she doesn't have any previous traces? How do we assess? Low risk woman who's just come, antenatal notes, fetal heart rate. So FHHR in antenatal clinic is not helpful. Okay, you miss a big, big opportunity to figure out what your norm for this baby is, because then you're just going with a generic, this is what fetal heart rates at 40 weeks are supposed to be. Does that make sense? Mm-hmm. So Looking at this lady's traces, this is a 28 plus 2. She here was presenting for reduced fetal movements. This is at 36 plus 6. She again presented with reduced fetal movements on that date. Obviously, you can see that towards the end. So on both traces, towards the end, the baby wakes up and it's happy and active. Okay. She also had a growth scan at 36 weeks, which said that baby's growth was perfectly fine. 38 plus 4. She's now coming in latent phase, so prolonged latent phase / contractions. Similarly at 39 weeks. Okay. Now we've seen the traces. We've seen the antenatal care. Okay, well, what's the current situation? The current situation, she was coming for induction and she's contracting on her own. So we've now built up a picture in our heads about what's supposed to be happening to this baby and what this baby has been doing for the previous events of pregnancy. So now we need to set the limits for this baby, the normal limits we're expecting for this baby before we ever lay eyes on the trace. That prevents us from becoming biased about, because the moment you set eyes on the trace, you've now created a picture in your head and your mind tries to put things at normal. But if you are trying to, if you estimate where this heart rate is supposed to be, what it's supposed to look like, you're more likely to pick up any things outside the norm. So what do we think is normal for this baby?
So she's 40.
She's 40 plus 2. We've looked at her previous traces. Okay, we can go back and look at them again. Okay, so this is what it was at 39 plus 1. Okay, this is what it was at 38 plus 4. And 36 plus 6. And 28 weeks.
So we're expecting around 140.
Okay. So remember 39 plus 1, the baseline here was about 120, 130. Okay. Here again about 140. That's the day before. So around 140. Shouldn't be any higher than that. Okay. Now, am I expecting contractions? Has been around. Okay, so potential contraction. Well, she was contracting. Am I expecting normal variability? Yes.
Yes.
Everybody's supposed to have normal variability. Yes. Okay. Am I expecting accelerations? Maybe.
Yes.
Okay. Accelerations? If she has contractions, then potentially yes. Okay. So before we carry on with that, let's ask again, because everybody talks about, yeah, we're expecting the baseline to be. You just said you're expecting the baseline to be 140. What is the baseline? How do you describe a baseline? So contractions are easy. Contractions, the TOCO and the, well, the bell-shaped curve on the TOCO curve, yeah? But talking about the baby's features, what's the baseline?
My words, but you've got like cubic squares, straight line, well not a straight line, but stable baseline. And that's when you can tell it baseline.
Okay, that was not very helpful. So if you want to define a baseline, how do you define what the baseline is? How do you calculate the baseline? Anyone online? What does the word baseline mean?
It's the average.
No.
Low.
Average is average. Or mean, or median. But what does the word baseline mean?
Baseline would mean that most of the time the fetal heart rate is maintaining that rate, and it should be at least more than 2 minutes in the length of 10 minutes to determine that what it is.
Did you hear what she just said?
What I said.
So that's, okay. I was just going to say that's missing something very, very important.
No acceleration.
Yes. Why? So she comes in front of me. This is distracting, being hidden behind the chair. Sorry.
Why? I don't know.
So Robin was just saying that with the CTG with no where there's no accelerations, decelerations. Yes, but why? What's the idea behind no accelerations, decelerations?
The baby lives.
Your baseline. So you want to figure out what the baby's heart rate is supposed to be when it's resting, when there's nothing else happening. Okay, that's what baseline means. So it's at the base when there's no other activity. So what you basically do, you're gonna block out any accelerations, any decelerations, or any episodes of increased variability. Okay, see what's left there, and then you take the average number of that, and that will give you a baseline. Okay, does that make sense? Okay, so what's variability? What's variability?
The balance between parasympathetic and sympathetic, which is giving beat to beat variation.
Okay, so you said two things that are not necessarily correct. So the balance between parasympathetic and sympathetic doesn't give you the variability, it gives you the baseline. So if you have more sympathetic activity, you have a higher baseline. If you have more parasympathetic activity, you have a lower baseline. But it's the interaction between the sympathetic and parasympathetic that gives you the variability. But that still does not define what variability is.
The range.
So the bandwidth, pretty much the range at which the change is happening. So basically how wide the oscillation is. And when you assess variability, you assess it within a minute. So you can't compare minute to minute. So I can't compare this to that and say, well, yeah, I have a variability of 20. Okay, I have to compare within the same minute and say, actually, here the variability is about 10 to 15. Okay? And cycling is showing that the baby is changing between the different states of activity and variability as well. So that's what we call cycling. Having said that, we are trying to assess whether baby's falling asleep, waking up, playing, falling asleep again. You can't fall asleep if you are running a lot of adrenaline in your system. So if you have a raised baseline, loss of variability is not cycling. It's usually baby becoming more unwell. So this is either decompensation or baby is becoming septic so much that it's almost very sleepy or fainting. Does that make sense? Baseline and variability basically tell you fetal status. Everything else on the tray, so accelerations. So what's an acceleration?
Baby's heart rate going up in the moves, or?
So baby's heart rate going up, okay, by how much, for how much?
20. I don't know, I'm guessing. 15 for 15 seconds.
So 15 for 15. So that's for a baby that's beyond 32 weeks. Before 32 weeks, we accept 10 for 10. Okay, so it's a rise by 10, or sorry, by 15 beats for 15 seconds or more. Okay, any other things within the definition?
And it always comes back to the baseline.
So it starts from the baseline and has to come back to the baseline. Okay, and it's an abrupt rise. It's a rapid rise. Rapid rise means that it happens within less than 30 seconds. So the idea is that if the baseline is going up over the next 2 minutes, that's not an acceleration, that's the baseline rise. Okay, and if it's settling over the next 2 minutes, again, that's not an acceleration. So it's a fast rise, fast drop, starting from the baseline, coming back to the baseline. Why are we using such strict criteria to describe an acceleration?
So that it's very clear that if the baseline rate is going up, that you are aware of it and flag that up early, because it could be a
So of course that's an important bit, but the main reason is that people look for accelerations as a reassuring sign, which is true. So if baby is moving, it's because baby is happy and it can do so. But it's also important because people look at acceleration and then look the other way to make sure you're not looking at overshoots or shouldering and saying, yeah, baby's accelerating. Okay, so it has to be a very strict thing. As a rule of thumb, if you're squinting to find an acceleration, you probably don't have any. Okay. Okay. Decelerations are basically the drop 15 for 15. And there are 3 types. And variable. Okay, so early, late, and variable. Early happens with, that's usually for head compressions. Late happens usually delayed, or it's actually a delayed drop or a delayed recovery. And that means that there's a chemoreceptor element to or component to the deceleration. Variables, which is the most common, so 85% or more of deceleration are variable, it's just for cord compressions. They're sharp down, sharp. Okay, and those tell you how baby's responding. Okay, which one do I like seeing more on the trace? If you are to choose a response on the trace, which one would you select?
Early and variable.
Early and variables, okay? So I generally like decelerations much more than accelerations because I feel that they tell me a lot more about the story. They tell me a lot more about how baby's coping rather than just, yeah, baby has moved, big deal. And when we did the masterclass the other day, we also saw how cord compression can actually show accelerations rather than a deceleration, which means that actually it's not necessarily very reassuring. Okay? So having said all of that, the first question that we need to answer when we're assessing a baby is this baby fit for labor? And the way we do that is now we're going to lay eyes on this trace, and the first thing we need to ask ourselves is the baseline on the trace appropriate for this baby and for similar babies at the same gestational age, okay? And that's where seeing the baselines from the beginning is very, very important. Because yes, baseline of 150 is normal. For this baby, would that be normal? It'd be high for this baby. Something's wrong. Although, if I had looked at it, yeah, it looks like it's normal, and I would have missed the fact that the baseline is actually high, okay? Is the baby showing normal variability? Is it still cycling? Okay. If yes, then it's great. If no, then okay, why is that happening? Is this baby still accelerating, especially if it's in early labor or latent phase? Accelerations later on, not very important, okay, but also whether there are accelerations or not. Are there any shallows or late decelerations? Or basically, is this placenta already showing signs that it's not coping very well from the very beginning? Because if the baby is already having a high baseline, so it's already responding, it's already stressed, it's not actually cycling anymore, and there's shallow late decelerations, do you really think this baby is going to withstand going through the rest of the process? Okay. One of the biggest improvements that since we started physiology we've actually managed to achieve is highlighting the babies that are not fit for labor and getting them out of the mix earlier. Yet we're sometimes still too late. Okay. And is there any other risk factors like meconium or chorioamnitis? This is your first assessment when you're ever assessing a baby for the first time. Okay, that's your first impression. So if we're looking at this trace, we're going to apply exactly the same. So this is the same lady. We're now 40 plus 2. This is 1 o'clock in the morning. I'm going to block out all the responses on the trace. And now I can see that the baseline is actually about 120. Is that normal? Is that appropriate for this baby? Slightly lower, but she's contracting. Is that so being slightly lower, is that a good sign or a bad sign? Is that a sign that baby's stressed or that a sign that baby's chilled out? Chilled out a bit more. Potentially with baby's head coming further down, that's also a normal thing. So the baseline tends to come down because there's more pressure on the baby's skull, hence vagal nerve. Okay. Okay, so variability seems to be fine and the baby seems to be cycling. So some activity there, nothing, and then some more activity there. Yeah? Okay, so we're happy with this trace? Cool. Now, the other thing that you would have noticed that they had started her on Stan. We are going to talk a bit more about Stan in the near future. So we'll talk about how do we manage Stan, especially because we here are using a slightly changed, different guidelines for Stan that we've managed to work with and improve. Okay, so baby seems to have a stable baseline. It's happy. Once we've established that this baby is fit for labor, any future assessments, you are going to start off by doing just a basic description. Always start out by remembering, okay, what was the previous baseline? Where did I start from? Because noticing that there's a change in baseline with time is the key to picking up chorioamnitis, infections, stress, etc. Okay, so just a basic description of what is, my mouse has disappeared, original baseline. What's the baseline right now? What's the variability? Are there any accelerations, decelerations, and what type? Okay, that's just the basic description to focus on the trace. The questions that you need to ask yourself: has the baby's baseline gone up? Because that may mean that baby is developing chorioamnitis, or it may mean that baby is becoming more stressed. There's compensated stress. Are the contractions becoming too narrow, too close together? Which means that even though baby is fine at the moment, it means that this baby might not be able to cope with in the future. Okay? Are the contractions lasting for too long? Once again, this is about being proactive. Don't wait for problems to happen and then try and catch up. If you can see that the contractions are lasting for too long or they're too close together, space them out. Even if baby's fine at this point in time, this baby's not going to be fine 2, 3, 4 hours later. Remember, she's a primate at 6 centimeters. How many hours do you expect that she's going to be going? A good 8 hours at least. Yeah. So if there's too many contractions, this baby's not going to tolerate that. And I can act now rather than having to stop things later on. Is cycling still maintained? Any abnormal variability or any other risk factors arising in the process? That's how you make your hourly assessment. Okay. You always need to make sure that you can see or you comment on any hypoxia that's present. Okay. And what's your management plan moving forward? Okay. So for our current baby, baseline has remained pretty much the same. Okay. She is contracting well, it's not picking up properly here, but let's say 1, 2, 3, 4, 5. Yeah. Okay. Some of them are 90 seconds apart. Some of them are not. They're not very regular, as you can see. But she seems to be progressing, so I pretty much don't need to do anything else. And baby's fine. Stan is also keeping a close eye, and Stan is also happy. So things are progressing further. Contractions we're now monitoring more, and they're more and more frequent. Notice again, no dates on any of the traces, no signatures from any of our colleagues, and obviously no patient information. Now, one of the important things that you will need to know as well, so when we're going to be asking about your assessments, most of our babies don't end up in NICU, do they? Most of our babies are well. Most of our babies actually have managed to make it through, sometimes despite our management and sometimes because of our management, okay? It's important that we are going to be presenting all. We don't know the outcomes for the baby, so you will only see the information as it unfolds along the way. Which takes out the element of, yes, obviously we're in a CTG meeting, hence this has to be a horrible outcome. Every single blip on the trace has to be now a late deceleration or a problem. Does that make sense? Just for the future, for when you're making assessments. Okay. Would anyone like to assess this trace? The other thing you're going to notice about me is if no one answers, I usually start calling out names.
So you've got a stable baseline with good variability.
What's your baseline?
I can't see from here, sorry, I'll have to unsocially distance. About 130. We are contracting a bit too much though. 1, 2, 3, 4, 5, 6 to 7 in 10. So I stepped out. So are we on Synto?
Oh, we're not in Synto.
We're not on
This
Synto.
is just spontaneous.
Okay, so we're contracting a bit much. I'll probably find out if she can, like, what are they like on palpation? Like, is she in labour?
She is in labour. She's 6 centimeters at her first week.
Okay, but baby's coping. So it looks like, yeah, I think baby's coping well, but it does look like she's contracting a bit much. It's tachysystole.
So tachysystole, baseline has remained the same.
Yeah.
There are some what look like accelerations, but the reality is they're cord compression responses. But again, I mean, we don't get bothered by cord compressions. So if anything's happening with this lady, we may need to reduce the contractions. Okay. So far, baby seems completely unbothered by this. So much so that we can think about, okay, shall we just carry on? We also have the additional monitor, which is the stand monitoring. So the idea about stand, we put stand on to try and make sure that we don't get any stand events. So if stand starts alarming, that means that hypoxia has reached central, the baby's heart. We don't want to reach that point. If we've reached that point, that means we need to act very, very fast. But in reality is we think that this baby is coping well, we think that this baby is not hypoxic, and we have an additional test to tell us actually baby's fine. Okay, so we're carrying on for another 1 hour. Anyone want to make another assessment?
It looks like the baseline rate was creeping up.
Looked like it was creeping up, as in this area.
Yeah, it took 130.
Okay, what about
But
here?
then it drops.
Then it drops again. Okay, why do you think that happened?
I'm not sure.
Okay, can anyone explain?
Well, it's like baby cycling, and you've got a bit of reduced variability compared to what you had before. Oh, sorry, I can't go back.
Yeah, I can go back.
But yeah, it looks like baby cycling.
So it looks like baby cycling. Okay, so lots of activity. And then the baseline settles to about 120, maybe a bit of waking up. Okay, but it's pretty much has been the same. Okay. And baby's awake again. So happy baby? We're happy to carry on. The other thing is you can see how the contractions are now becoming almost, I mean, we're contracting about 1, 2, 3, 4, 5, 6, 7 in 10. That's a lot. That is a lot.
She okay?
Well, she has an epidural and she keeps on topping it up, so.
Any bleeding?
No bleeding.
Uterus soft between contractions.
Uterus soft in between contractions, for the 10 seconds that you have in between contractions. Okay, so what would you like to do? Probably you'd like to re-examine her. Okay. I think the team were thinking along the same lines. So they asked her to examine and she asked for an epidural top-up first. Okay. And they examined and she's now 8. Okay. What do you think happened there?
So it looks like the baseline drops to, I can't see on the CTG, but.
Sorry, it's a bit
so is that?
That's 100, so that's 100.
So I'd find out what maternal pulse is, and then I think
the
about,
maternal pulse is the green circles.
Okay, so it does look like baby, doesn't it?
Yeah.
So she does have an epidural top up, so has she dropped her blood pressure? Could mum have had an episode of hypotension? Is she on her back? You know, is that precipitated, you know, from the cord or something? And the baby's having a bit of cord compression, so I'd probably turn her onto her side, change position. But it looks like it recovers. Yeah, so that'd be my first thoughts. What's mum's blood pressure doing, and is that baby just not happy with mum lying on her back if she's just been examined?
Okay, so yes, both of these are yes. So the first thing is the drop. She's probably on her back. I mean, baby is responding to our VE there. You can see lots and lots of accelerations. Well, what are we doing with the VE as well? So we're assessing dilatation. We're trying to assess position, etc., etc. There's a bit more head compressions and all sorts of pressure on baby's head.
Looks like baby's had an acceleration during the VE, so that's a nice reactive. The baby's reacting.
So baby's very responsive and reactive, which is good. And now that we have her still on her back, obviously that's why baby's a bit more tachycardic afterwards. And as you correctly said, just move her off her back and most of the time baby will recover fine. Okay, so we now have her on her left side, but it looks like baby's baseline is still high. Okay.
What's the baseline now?
So the baseline there is one. I think it gets a bit clearer. Next slide, yeah, 140. Anything else that you can see that looks different? Yeah. Pseudosinusoidal. So the sharps is the pseudosinusoidal. Okay. But we know that baby was responding fine. So that would make me think again, okay, well, pseudosinusoidal trace can happen when there's a bit of bleeding. There's no bleeding on assessments and on VE, or not on when we made the assessment. Could there be a bit of bleeding behind? Okay. Can there be a bit of bleeding that's hidden inside? Potentially. The thing was that this baby's head was quite low, so it was at spine zone VE. It was OP at the time, and that's just the response from the VE. We could not explain that any further.
It's quite difficult to see what the contractions are doing there as well. Like doing the distillery, that's okay.
Yeah.
Find out how much is she contracting.
Do we want to change anything in her management?
What was the duration between the 6 centimetre and 8 centimetre VE?
3 hours. So as long as baby's coping, okay, we don't need to do anything at all at the moment. We have an extra reassurance that's also telling us baby is actually centrally, baby is also fine. And I know that it doesn't not mean a huge amount. Sorry, people have fallen out and joining back again. Sorry, I know that the change within here. So you can also see how wavy the trace, the stand monitor is. I'm not going to go into too much details there, but if this is becoming more wavy, we can start also acting a little bit sooner, even if it doesn't alarm. Too far at the moment, let's not. But Stan is stable and the baby is actually improving with this. Yeah, baby's baseline is coming slightly back down. Okay, and we're back to the accelerative cord compressions, even though I'm still saying contractions may be a little bit more too frequent for this baby. Okay. Okay. The next question is this baby's baseline stable enough for me to carry on? Or is this baby showing any other signs that it's unhappy? So Stan is not alarming, which is a good reassuring sign. Physiology-wise, there's a slight rise in baseline. She's also becoming a slightly tachycardic as well, if you've noticed. So that may be going towards possibly infection. But the first culprit in all of this, she's contracting 7 and 10. If I'm going to do anything, I'm going to assume this baby is becoming a bit more stressed just by the frequency of the contractions. Yet, this baby is not hypoxic because it was responsive as well on my examination. Does that make sense? Okay. We're pushing this now to the limit because now we have the extra reassurance, but the baseline is going further up. If we're not using Stan, this would have been, okay, this is a compensated stress and we might need to make this better. I would have been tocalizing. But I have the extra reassurance of Stan as an extra marker, and I can see that even though, so these are all cord compressions, I would try and space this out and make sure that she's in a good position. Okay. I know we're just about reaching the time limit. Okay. She's once again 8 centimeters, so she hasn't progressed given those ridiculous number of contractions that she's had. Okay. But she asked for, can you, oh, sorry. What's happened? What happened?
It's just randomly turned off. I think it lost connection, but the whole computer's. But we can maybe look at I'll try and log on again.
Yeah, you will need to log on to Zoom again.
I'll be disconnected. Otherwise, it might
Yeah,
be easier to just
yeah.
that.
Okay, can you guys see from here? Okay, so we're getting more and more of this sawtooth. Sawtooth we always link with, or we sometimes link with baby bleeding. Okay, but baseline remains to be stable. Stan seems to be completely fine still. If not, this would, if we haven't done so already, this would definitely be the time to think about tocalizing. Okay, but the problem now is we have to think, well, she was 8 centimeters and then 8 centimeters again. The first instinct would be to start synto. Would I start tocalizing? Do I think that's a management of labor? She's not progressing already. How does that work? What do I do? Okay, that's an easy answer. No, think realistically. So she's contracting 7 and 10. I should not be starting syndrome. She's not progressing. How do I balance that out? Why do you think she's not progressing?
Position.
Potentially. Do the 7 and 10 contractions help her progress?
Probably not much effort. Force.
So they're not relaxing enough. So the uterus has to contract, stretch the cervix, and then relax to allow the cervix to stretch. If it keeps on cramping, those don't help. So the reality is, if you try and relax this uterus, you may end up with better progress than forcing the contractions to be stronger. You will also end up with a happier baby. Yeah? And that's pretty much what happens. So she gets localized. Now, when we give terbutaline, we will talk about that at some point when we talk about medications. When we give any medication, we have to figure out or to expect what we're going to be seeing on the trace. Given that now that the contraction has spaced out a bit more, the baseline is still the same. Hello? No? Okay. Yeah, no one's waiting to admit it. So when you give terbutaline, terbutaline is a beta-2 stimulant. It is supposed to make your heart rate go faster. But remember, you're giving this because there's adrenaline in baby's system. So that should take away the adrenaline. Hence, the baseline should remain pretty much the same. And it should not be going even higher. So she gets terbutaline at this assessment, so around 10:20. Okay, and contractions seem to start spacing out. The baseline has remained stable. The zigzag pattern that we were seeing is actually going away. So this was baby becoming stressed. Okay. She's also getting some IV fluids just to try to wash out or to improve the perfusion to let this baby settle. And the baseline actually settles back to the 130 baseline with normal virility and occasional accelerations / cord compression accelerations there. Okay, and baby's actually back to cycling. It can fall asleep. And now she's actually progressing. So 2 hours later, 2.5 hours later, she's now cervical ring. You see that? So with terbutaline, we actually made her progress rather than pushing her more and more, and then she will end up with a C-section. Yeah? She's carrying on. She's now being assessed an hour later, and she's fully dilated at 120. Okay, she starts active pushing. You can see that the baby's coming back slightly to that zigzag pattern again. Although in general, baseline seems to be stable, and Stan is completely stable. Sorry. And she achieves a vaginal delivery an hour later. What do you think the outcome of this baby is going to be?
Good.
Yeah, that's not an answer. So how do you assess outcome? We assess outcome by 2 measures. Outcomes and gases. Yeah? What do you think the outcomes are going to be like? Online team?
7, 8, 9.
Why are you saying that?
Because sorry, it's echoing there.
Again?
This is going to be good outcome for the baby.
Okay, how have you estimated there's a good outcome for baby? How did you figure out what the outcome is going to be? Joe?
Sorry, I thought it was might be echoing. I'll just write on the chat.
It's going to write on the chat, sorry.
I think these APGARs are going to be 9 and 10.
Okay, you still need to explain.
Because even right at the end of the trace, the baseline's stable and the variability is good. So I don't think this baby is too stressed by active second stage.
Yes. Yes, that is completely right. So as Joe also wrote, so there's good cycling, good variability towards the end, just before the delivery. There's not, so what you're looking for towards the end is if there's prolonged episodes of this zigzag pattern, this baby's gonna be born actually quite floppy because it's panicking towards the end. If this is what you're seeing towards the end, the baby's happy, okay? If it's obviously completely flat, this baby's gonna take a longer time for resuscitation. So yes, I accept the 7, I accept the 8 because it's not gonna require much resuscitation there, okay? And the gases I would expect to be completely normal, which they were. So this lady, we actually delivered her by terbutaline rather than with Sinto. Does that make sense?
Yeah.
Did we understand why? You missed that.
I missed the drama.
You sectioned her and then left.
I did, yeah, it was like done.
Okay. So the main purpose of this was obviously that how to present, how do we describe traces. Okay, we're going to be talking about the guidelines. So we're changing the hospital policy because we are adding in the new STAM guidelines, and we're making a decision tree that's supposed to help. I think Gabby and Vanessa would have talked to you at induction about this.
Yeah.
Okay, so we're going to enforce this with our teaching and how we're going to be presenting this. Does that make sense?
Yeah, thank you, Ahmed.
Do you have any questions? Thanks, Joe. Does anyone have any questions? Cool. Thank you very much, guys. Enjoy the rest of the day.